Great. Thank you, everyone. My name is Hashim Ahmed. I'm one of the urologists at Imperial, and I'm one of the co-lead applicants for the AVIDITY trial. Some of you will know me. We run a number of portfolio trials at Imperial, and some of you will be involved in some of those other trials. So hopefully you can take part in AVIDITY. It's been a long journey getting here. In my email to the sites, I've outlined the fact that we went through a number of funding rounds for this, but I think everybody agrees this is a really, really important study. And as more and more of us do and use PSMA PET imaging in clinical practice, I think the realization has come that we do need to evaluate its clinical utility. We know it's more accurate, but is it more useful? So I'm going to allow the people here to introduce themselves and then hand over to Martin Connor, who's going to present the background to the study, and then Tara and Henry will be also presenting on the PSMA aspects of QA/QC and how we're going to use the imaging. Ladies first, Tara.
Hi, I'm Tara Barwick. I'm a radiology consultant at Imperial.
I'm Martin Connor. I'm a clinical lecturer here at Imperial.
And I'm Henry Tam, also a radiologist at Imperial.
So I know there's lots of people on the call. Just for the interest of time, thank you for all coming on board. We won't go through individual introductions if you don't mind. This will be recorded. There will be a Q&A bit at the end for you to put in questions in writing or verbally if you wish. And obviously it's a two-way thing ongoing as well. So feel free to ask us anything after the call is finished. And then this webinar will be sent out to everybody who's registered for this. And then feel free to circulate it to other colleagues as well. Martin.
Brilliant. Thanks very much, Ash. So we'll work through the slides covering Avidity, and then there'll be a Q&A section at the end. So hold your questions to the end if you can do. I'm Martin Connor. I'm a clinical lecturer here at Imperial, and we'll be bringing you Avidity hopefully to your hospital soon. So AVIDITY stands for Assessment of Variation Imaging of Distant Involvement on Treatment Pathways in High-Risk Prostate Cancer. And we'll take you through what that trial looks like. Just to welcome the other leads who are not here, we have Professor Rhian Gabe and Dr. Adam Brentnall, both from Queen Mary's University of London, who are statistical support for this study. In terms of the protocol development group, I know a number of you have been in part of that, and it's been a bit of a slow journey of a journey over a couple of years, but we thank you. We couldn't have made it to this point without you, and we think it's a really important study. Radiologically, we've got Professor Anwar Padani and Dr. Henry Tam, who's next to me here from the Paul Strickland Institute and Imperial, respectively. Surgically, Matthias Winkler, Tamer Shah, and Tim Dudridge from Imperial and Southampton. And then we're very happy to have radiology and SABR support from Dr. Stephen Manga at Imperial, Dr. Vincent Koo at the Royal Marsden and the ICR, and Dr. Darren Leaning up at James Cook University, with medical oncology support from Dr. Naveed Sarwar here also at Imperial. And our health economic analysis, which is a major part of the study, comes from Professor Luke Vale at Newcastle. As part of this study, we did contact NHS England to determine the threshold for commissioning of PSMA PET, and most of those discussions were held with NHS England with Dr. Mark Lambert. And we have had some collaboration internationally to discuss other PSMA intensification studies, such as Patron in Canada. So funder and sponsor, so very pleased to announce a funding envelope of 1.9 million from Prostate Cancer UK just in April of this year. And they'll be supporting the study, which will be run out of our Imperial Clinical Trials Unit. I know many of you know us from our other multi-centre randomised controls trials, and they have a lot of experience working with us and delivering those nationally. Avidity will be, we expect, badged on the CRN network and supported. And Newcastle University will be supporting us with the health economics component. So as Hash said, we know that PSMA PET is definitely more accurate in diagnosing prostate cancer metastases than CT and bone scan. We've known that for some years. Pro-PSMA from Hoffman and colleagues in Melbourne told us that in 2020. And of course, we've had Osprey and other studies confirming that. But what happens when we try and translate those metastases we detect on PSMA to our real world clinic and MDT? It gets a bit more tricky. So these are all pretty well run arguments of what happens when you try and apply this new molecular imaging to historical definitions, staging pathways and management pathways of those. You get stage migration, you get length time bias, you get lead time bias. And when you get a combination of all these, we think you probably get a real Rogers effect, where you get a movement of patients between the different risk groups and a paradoxical rise in overall survival in all those groups. So it is tricky, and this study helps us try and understand what to do. When we look at the guidelines, they're not much use, to be honest. The latest EAU guidelines from 2024 tells us that the ideal management and prognosis of patients diagnosed with metastatic disease on these more sensitive tests is unknown. But in particular, it's unclear whether metastases detected by PET-CT should be managed by systemic therapy only, or whether they should be subjected to more aggressive and local metastases-directed therapies, and leaves it up to you. AUA tell us that the identification of molecular disease may influence treatment, which underscores the current uncertainty regarding the incremental oncological benefits of altering treatment based on metastases that are confirmed on molecular imaging alone. ASCO tell us that after treatment decisions, after PSMA treatment decisions are altered with unknown consequences on the overall disease course. And if we look at our UK-based guidelines, NICE say nothing at all on PSMA PET, nor does it stipulate what staging tests should be done. But luckily, the Royal College of Radiologists and the RCP have issued a statement, but that statement says it's insufficient outcome data to recommend routine use in the setting. So we're a little bit lost on what to do. And that's why we do think we need avidity as an RCT. We need it for 4 key reasons. Those are that when we find distant disease, we start systemic therapy and ADT. And we know hormones for distant cancer on CT and bone scan did improve survival in previous studies. But as hormones cause side effects, we must be sure they also result in benefits for those who have metastases just on a PET scan. Some patients we know may avoid unnecessary harm by having avoidance of treatments to their lymph nodes, or avoid hormones because the CT and the bone scan has overcalled it and given us a false positive. We know that metastases can be targeted with stereotactic ablative radiotherapy, in addition to treating the prostate itself with surgery or with radiotherapy, but we need to confirm whether those extra treatments are beneficial when you see that disease only on a PET. And finally, probably most importantly for us working in the NHS, we need this level of evidence before we can commission PSMA PET CT, which costs £1,500 to £2,000 per patient compared to our existing CT and bone scan. So that's the background to the study. So what is Avidity? Well, it's a randomized controlled trial that's going to assess the clinical and cost effectiveness of PSMA PET imaging to stage newly diagnosed high-risk prostate cancer compared to standard CT and bone scan. Our hypothesis is that in patients with newly diagnosed, histologically proven high-risk prostate cancer who have no distant disease on pelvic MRI, M0, the use of PSMA PET CT for staging, followed by treatment refinement and key escalation to distant disease, in addition to standard treatment, compared to standard imaging of CT and bone scan, followed by standard treatment alone, will improve metastases progression-free survival, and we hope be cost-effective. So our aim is to show improvement in cancer control using PSMA PET CT guided treatment in patients with high-risk prostate cancer, and secondarily to estimate the quality of adjusted survival and cost effectiveness of PSMA PET CT compared to our existing standard imaging pathways. And that's our primary objective, which we've covered. So effectiveness of PSMA PET compared to CT and bone scan. We're going to use the endpoint of metastases-free survival in a randomized group up to 51 months after randomization. And the secondary objectives, adverse events, complications, patient-reported outcomes, and our health economic analysis of PSMA PET. So eligibility criteria, we're going to need to include patients who've got histologically confirmed prostate cancer, adenocarcinoma without variant. We're using the NCCN high-risk cancer definition, which is that of stage radiologically greater than or equal to T3, or an ISUP grade group 4 or 5, which is an old money, a Gleason score of 8 to 10, or a PSA above 20. We'll accept N0 and N1 on the MRI scans, but they must be M0, and they must be suitable for local treatment prior to entering the study, be that surgery or radiotherapy, as deemed by the local team, with a performance status of 0. And of course, be over 18 to enter the study. We'll exclude patients who can't undergo any of those imaging tests in the study if they've had local or systemic treatment to prostate cancer diagnosed previously, except for 5-alpha reductase inhibitors, if they've had another malignancy in the last 2 years, or if they have variant path or non-adenocarcinoma, spindle cell neuroendocrine differentiation. They'll be excluded as well. So this is our trial design. So I'll take you from left to right on the screen. So you'll see patients with high-risk prostate cancer. We're looking to recruit from up to 30 centres in the UK, with a total sample size of 475. Those who meet that NCCN high-risk prostate cancer criteria will then be stratified after consent using parameters for the presence of MRI nodal disease, T3 versus T2 disease, and whether they're suitable for surgery, of which there'll be some guidance criteria to guide you. They'll then receive all 3 tests. So they'll receive a bone scan, a CT, chest, abdomen, and pelvis, and also a PSMA PET CT. And they'll then be allocated their standard of care arm, where your MDT will be able to see either the bone scan or the CT, abdomen, pelvis, or the PSMA PET. In the standard of care arm, you'll follow existing guidelines. You'll follow the NICE guidelines, EAU guidelines, and your practice. And we've actually done a survey of most clinicians in the UK who do high volume prostate surgery and radiotherapy and found there is standardization in that practice. We'll expect you to come within that, and I'll talk about the various restrictions in each arm. Those patients will go on to have treatment as dictated by the MDT, and they'll go on to have mandated bone scans and CT scans at 24 and 48 months. At those points, if they're the unblinding of the PSMA PET CT that received at baseline, the radiologist will be able to compare the two. In the PSMA intervention arm, this really is an escalation study. So we'll ask you to escalate where appropriate, and there'll be a series of different PSMA guided intensification treatments available to you. Surgery and radiotherapy to the prostate only in N0 disease. As with standard of care, there'll be an allowance for pelvic lymph nodes and also pelvic lymph node dissection in those deemed high risk for lymph node involvement as per the Roche formula. Those who have nodal disease will be stratified to have either surgery or pelvic lymph node dissection if they were allocated as surgically suitable at baseline, or radiotherapy to the prostate and pelvis, including those nodes. Those with distance metastases of less than 5 will be eligible to have systemic therapy, radiotherapy, or cytoreductive surgery with nodal treatment and SABR to all identifiable METs up front. Those patients will then follow, as they would with the first arm, to have a CT and a bone scan at 24 and 48 months. But in this case, we'll unblind the other scan at that point. And we're looking for metastases progression-free survival at 51 months in total, and marking them off if they have it earlier. Just to cover the conventional imaging treatments, effectively, it's what you're doing right now and stick to that. So it's current NICE guideline determined care. We'll be looking within the pilot to see what variations of practice there are and to make sure that we've got a good degree of standardization in the treatment in that arm. But specifically things you're not going to be able to do in the conventional arm. You're not going to be able to give SABR. You can't do a cytoreductive prostatectomy, and we can't have patients having off-guideline or non-commissioned prostate radiotherapy at dose and fractionation schedules that are not commissioned for NHS England for those with low volume disease defined by the chartered definition for metastatic disease. What about this PSMA intensified arm? Well, these are the different options you're going to have. So if you have PSMA N0 disease, we'll be suggesting that you have a prostatectomy or a radical radiotherapy to your prostate, suggesting a hyperfractionated dose of 60 and 20. If your Roche formula is calculated that you have more than a 20% risk of nodal involvement, we'll ask you to escalate that to include whole pelvic radiotherapy and also a pelvic lymph node dissection as well. In N1 disease, in patients who have been pre-declared for surgery, they can go through to have their prostatectomy and pelvic lymph node dissection. In those that haven't, or their preference for radiotherapy, we'll ask you to treat the prostate and the whole pelvis, including those lymph nodes. In those with M1 disease, we'll stratify them, irrespective of their N0 status, to less than or equal to 5 METs or more than 5 METs. In those in the PSMA or molecular lower burden section, we'll ask you to intensify systemic therapy, give upfront SABR, and then treat the prostate either with surgery or radiotherapy as per the predetermined criteria, and that would be a side reductive prostatectomy with a pelvic lymph node dissection or prostate and whole pelvis radiotherapy. In over 5 METs or visceral METs, over 5 metastases, bone or nodal, or any presence of visceral METs, we'll ask you to escalate to triplet therapy and give local prostate radiotherapy as you would have done previously. So we made some assumptions here. So we know that metastases-free survival is the strongest link to overall survival as a surrogate, and that's why I've utilised this as the primary endpoint. And we think that overall in standard of care at 4 years, by taking all these high-risk comers, it will be 67% and 76% in those in the intervention arm, giving us a delta of 9. This on the basis that we're going to escalate local, regional and distant cancer treatment, and that's going to benefit. Analysis, we're planning to unblind and just ignore the patients who have had the same treatment, which we estimate to be about 60%, the N0, M0, and focus on the discordant group, those in the N0, N1 and the M1 group at various different thresholds. That allows us to reduce our sample size, which gives us a total sample size of 475 to power the study. Primary endpoint, metastases progression-free survival. So we've defined that as no new metastases or no progression of existing metastases if they have METs, or death of any cause, and that will be determined at 51 months post-randomization. We know that has a strong link to overall survival. Of course, if patients do fail prior to the 24 or 48-month mark, they are due to clinical concerns with the rising PSA. Clinicians will be able to request a full-cause scan, and those imaging tests will be unblinded to help make a decision on their treatment. The patient will still go on to have their mandated CT and bone scan at the time points determined at 24 and 48 months. Secondary endpoints, plenty of them on the slide, lots to look at here, split between safety, oncology, radiological and health economic. The safety endpoints really primarily adverse events, and we'll be looking at the new treatments in those arms. Oncologically, we're going to be looking at the different subgroups, how they're treated. There will also be some work looking at metastases-free survival in each of those groups. And radiologically, we're going to look at equivalent scans, reader confidence in the PSMA PET arm alone. There's also going to be some radiomics work embedded, looking for predictors of metastases-free survival, such as tumour volume, number of METs, presence of pelvic nodal disease. And then there's, of course, our health economic analysis that will help assist us in saying whether this trial is going to determine whether PSMA is going to be cost effective against bone scan and CT. So where does it start? Well, we'll start with a pilot, and that's an internal pilot, which will run straight through into main phase of 37 patients. And that's really just to determine the feasibility of our study design, to make sure we don't have too much contamination and non-compliance in the study, to look at the frequency of that N0, M0 rate to make sure that we've got our formal and full sample size correct, and also how often that local teams might ask us for unblinding for clinical concern or patient dropout because of poor acceptability for the study. Once we've met that 37, we'll bring it to our trial steering committee, and a recommendation hopefully will be made either way to proceed to the trial design, which is the one that I presented to you. So there is another trial design that we will consider at this stage, which I haven't presented to you, which does involve a larger number of patients, and we will defer that to the question section, but that is another option to allow the trial to continue should we have any issues at this stage with the initial trial design. So that completes the overview of the trial design, and then I'll just hand over to Tara for the imaging section.
Thank you, Martin. So it became apparent that we should not limit to one particular PSMA tracer so that we could make it real world for UK and recruit as many patients as possible. So patients can have any of the clinically available PSMA PET radioligands. In order to be a trial site, you would need to have access to one of or more of these PSMA radio tracers. All centres will have PET-CT scanner accreditation by the UK Core PET Lab for that specific PSMA tracer. We will need each centre to have existing experienced PSMA RSAC holders on site, ideally at least 2 reporters. Each centre will need to be capable of anonymising and transferring data to the core PET lab at St Thomas's Hospital, and also capable of blinding data on their hospital PAC system. Next slide, please. So we will have detailed SOPs as regarding imaging reporting criteria. Reports will be performed locally by the experienced PET-CT reporters and nuclear med physicians and radiologists. We will follow the PROMIS version 2 guidelines for PSMA reporting. I'm not going to go into detail for this, but this does include a 5-point level of confidence score. Scores 1 and 2 will be considered negative, 4 and 5 positive. And in cases where there's a score 3, which is equivocal, those will all come for central review. In addition to that, at least the first 10 patients for each centre recruiting will come for centre review as well, just to ensure QA and QC across the study. We want to avoid as many patients as possible to be unblinded. There will be detailed SOPs for the convention of care arm as well, and reporting of the CT and bone scans, and how we manage any equivocal findings in that arm, because where possible, we want to avoid unblinding of the PSMA. We know from the PRO-PSMA study that there were equivocal findings in 23% in the convention of care arm, but we will have very detailed SOPs on how to manage equivocal bone lesions or liver lesions without unblinding. But we do appreciate that ultimately there will be a small fraction that will need unblinded. Next slide, please. So as mentioned, we are using the UK core PET lab based at St Thomas's Hospital. Each centre will send pseudo-anonymised data directly to St Thomas's. From there, we will download all the PSMA scans centrally to Imperial for a kind of PSMA biobank, and in order to do our radiomics data analysis, etc. And that's kind of the main things about the imaging at this stage. I'll not take up too much of your time on that, but...
Perfect. So just a brief overview of the timeline. So we're in the regulatory approval phase, which will give us a multi-site opening date tail end of this year, and we'd expect that pilot 37 to be recruited, if not well before around July of next year, giving us a final patient recruit of December 2026 and a final readout of the study in October 2029. Perfect. So we're within our time bracket for the Q&A section. We'll just stop sharing the screen here. I don't know, Hash, if you want to chair that section.
Yeah, so if anybody has any questions, they can write them in the chat box, or if you want to unmute yourself, and feel free to throw us any questions you'd like. Sorry, we're looking at a laptop here, but the video is over there.
A couple of hands up. Alistair Lamb, should we take you?
Hi, thanks Ash, thanks Martin, really helpful explanation, super to see the detail. Just a really basic question, apologies if we thrashed this around lots before. Why limited to just high risk disease and not unfavourable intermediate?
We did think about it, and PRO-PSMA did include some intermediate risk disease, but I think ultimately we have to sort of project where we see the greatest use of PSMA PET imaging, and it is for those cases where we are predominantly staging with CT and bone scan. Not all centres are doing distal staging for unfavourable intermediate risk disease. And also, the minute you start to include that group, you are then diluting your endpoint, and therefore you need a much bigger study. So I think it's a key question. It's a really important question. we won't be able to answer it. But if we show utility in high risk, then I think it's justifiable to start to look at the intermediate unfavorable group as a separate entity, or maybe as a parallel study, if you can convince, somebody can convince a funder to tackle it. But the endpoint is very low in that group, and therefore I think we'd be looking at quite a sizable study, which would be problematic. Good. Who else? We'll take it in order of hands up. So Vish from Liverpool.
Hi, Hash. Just query on the PSMA, because we are going to use a different PSMA tracers. So how the numbers are going to be to avoid any bias between the data?
Well, we've got 3 different PSMA tracers. I don't think it's going to be a problem, because none of the 3 tracers has been shown to be any better than the other in terms of detecting disease. Certainly, there are some differences in terms of potential false positives, and definitely with some of a couple of the tracers, you need to have experience in terms of reading so as to not overcall certain things. But I think that in all the literature to date, none of the 3 tracers has been shown to be more superior in detection of disease.
Does that answer your question, Vish?
To some extent, because we know that gallium is much more at least in the clinical picture, and the difficulties getting a gallium is quite difficult at our center in Liverpool. So yeah, I agree there is no evidence, but how do we match to get the best outcome or correct results from the trial? So are we going to have an internal matching between the subgroups of the different PSMA tracers? Analysis?
It's not something that we considered, but we can certainly do an interim analysis looking at if there is any variation in the tracers. But in the UK, there not many centres have access to gallium, and most of the centres have better access to F18. And actually, that is probably going to be what will happen in widespread clinical use, because most centres do not have access to a gallium generator. The half-life is shorter, 67 minutes. And, you know, I think even if you look across the world, more and more centres are using F18 PSMA because of these reasons.
It was something that we, 3-4 years ago, we looked at, and we tried to go with one tracer, and actually the peer review and panels and the funders went the other way and said, this is crazy, why are you just going with one when the UK is going to end up using 2 or 3? And therefore, this is going to be a study of this tracer, not a study of PSMA. So we were sort of caught between a rock and a hard place. And I think whilst many aspects of the study are not necessarily pragmatic, the use of whichever tracer you have local to you that your patients can get to within a reasonable travel time made most sense. And I think it will be difficult to look at subgroups because the different tracers will be geographical. And so therefore we won't be able to stratify the randomization to equalize the different types of tracers in order to make the subgroup analysis robust. So really good point, and we may have a sort of a weak subgroup analysis as maybe the 2 or 3 years down the line after we finish the study, but it will be significantly criticized because we didn't do stratified randomization for the reasons that, you know, your local center might be just gallium or F18, and therefore we can't stratify randomization. Next question is, thank you, Greg Shaw from UCLA.
Yeah, hi Hash, hi Martin. I was interested to see cytoreductive prostatectomy in the protocol, and I just wondered if you could clarify, are patients for cytoreductive prostatectomy going to be protocolized, and if so, which are the patients who that's going to be appropriate for?
Yeah, absolutely, we're going to include it. But Martin, do you?
Yeah, I could say. So we're going to include patients who up front you've declared would be suitable for surgery, or preferences for surgery up front. If they are drawn through and end up in that low burden, molecular low burden group, they would be eligible for a cytoreductive prostatectomy in that group.
Okay, interesting. Have you got any idea what sort of proportion of patients? Because I don't know if there are many centres doing cytoreductive prostatectomy in the UK.
So in the standard of care arm, definitely not. So, but in the intervention arm, we will allow it. But these are patients who you will deem suitable for surgery prior to randomization. So these are high-risk men who might have a PSA of 22, or might have a Gleason 8, but it's a small tumor, and you would normally offer them surgery. If they didn't have MET, they would then be able to choose to have surgery in the intervention arm, even if afterwards they did go on to have METs on PSMA.
So maybe I misunderstood, Hash, but are the patients who are then having PSMA going to have bone scan and CT chest abdo-pelvis as well?
They will, but they will be blinded.
Okay, so
you won't know though. They will have an MRI. They should have had a diagnostic MRI. So you should know the technical aspects of the local pelvis.
Okay, but I don't think in high-risk disease we wouldn't make a decision to offer surgery until we'd seen a negative bone scan.
Guess what we're saying is we would like you to offer surgery on the basis of a negative PSMA, but even if they had a positive PSMA and you deem them technically and physically fit for surgery before randomization, you would still be able to offer them surgery to their prostate, plus or minus pelvic lymph nodes, even if they had METs on PSMA. But that's part of the treatment escalation within the intervention arm.
And I think if we look at the pro-PSMA data, I mean, 8% of those went on to have prostatectomy, even in the presence of distant disease. So we're trying to find out whether there's still a role for that within this escalator pathway, and that's why we're allowing it. But it's going to be based off that MRI and also their fitness, and you have to pre-declare it before randomization. So small numbers.
Okay, I hear you. Thank you.
Thanks very much.
I don't know whether, Greg, we answered your question, but or answered your concerns, but it's something we will continue the discussion on. I know some people are very keen on offering surgery in this trial in the intervention arm. There is some reticence amongst some surgeons. We will allow for that in the wash per centre. So we're not going to force you to do surgery in cases that you don't want to. That's one reason why it's both surgery and radiotherapy is allowed. And as we found in Atlanta, when it comes to it, actually a lot of them have radiotherapy to the prostate. But I think there are plenty of surgeons who would like to operate and see what the utility of surgery is in this group.
Okay,
great. Next question is from Vincent. As long as you don't say, hang on, I'm not involved in this, am I? Then
I was going to say really nicely presented. So thank you so much for the data. I'd like to come back to what Vish highlighted, which was one of my concerns. And I know Tara's highlighted the false positives, particularly with the F18. But I wanted to stretch your answer on stratification, because clearly centers, as you've highlighted, will have one or the other, not all three. And mine would be gallium. But why can't you stratify the randomization per center once they've nominated it, so that you get a equivalent distribution in both arms, just in case that it ended up with, say, one center who is predominantly gallium, all going into the metastatic sort of, radical treatment scenario?
Vincent, thank you very much. That's a really, really good suggestion, and we'll take that back to Rhian and Adam. And stratification by centre effectively means we're stratifying by the tracer. So we and we'll link the two in. We'll take it back to Rhian and Adam, our lead statisticians. But no, thank you. Thank you for calling.
That would be a less
Rhian's here.
risk. Oh,
Rhian's on the call.
Oh, okay.
Yeah.
Sorry,
Is it-
Rhian. I didn't. We
yeah,
should have introduced you right at the.
It's fine. When you was talking about it, I was thinking what Vincent was thinking already. Anyway, so
Thank you.
yeah.
Thank you.
Yeah.
Brilliant. Thank you. Next question. Vish, do you have another question? On
Yeah,
the
so-
legacy hand. Yeah.
Sorry, taking back from that only, I assume the follow-up scans for the PSMA will be the same PSMA tracer will be used in that center. If one patient has had F18, even if they have two available molecules, they will use the same tracer. Are we going to ensure that that is happening? Sorry.
So we're not going to use protocol mandated PSMA imaging follow-up. The consensus guidelines show that METs on CT and bone scan are validated for overall survival. And that's why we've gone with 24 and 48 months CT and bone scan as mandated imaging tests. But we won't be using mandatory PSMA PET imaging at 24 and 48 months.
Oh, sorry, I missed that. Okay.
Yeah.
And can you just share the trial protocol? I mean, is the bone scan is done after the biopsy? Was that, I just missed
Correct.
that bit.
Yeah. So after randomization, all patients will have bone scan, CT, and PSMA. In the control arm, the clinical team and the patient will know what the bone scan and the CT showed, but the PSMA PET will be blinded. The report will not be issued locally, and we'll talk about how we will do that, but there's precedence in how we do that with the PROMISE MRI trial. So you will use your bone scan and CT in the control arm and decide their treatment. In the intervention arm, those men who have been randomized to intervention arm will have their bone scan and CT blinded, and you will not see the reports. We will ask you to not look at the imaging. So you will be asked to sign a declaration and adhere to ethical and professional standards of not looking at those imaging tests. That's what we did in PROMISE as well. But you will see the PSMA and the PSMA PET report in the intervention arm, and that will then determine your ongoing care. So
Yeah,
sorry, carry on.
So there's a slight change because most patients, if they are more than PSA 20, they would initially, as a 2-week rule, they do have a bone scan. So we'll have to have those as a different plan for these patients, isn't it?
Yeah, so I mean, in our center, we MRI everybody up to a PSA of 80. So we don't bone scan immediately those patients. So they might still get a CT and bone scan, but we do still MRI them. So I think you obviously have to look at, there are various issues to taking part, and we will obviously, you'll need to consider whether the study fits in with your standard approach to staging. And if it doesn't, can you make changes? Will your local MDT be happy with those local changes to how you handle your staging pathway? And that will be an individual center decision. And ultimately, there may be some centers who say, look, this is not for us. We just can't make sufficient changes. Okay, fantastic. Are there any questions on the chat that we should be handling? So will whole body MRI be allowed as part of conventional imaging? We were chatting about this earlier.
Yeah, I mean,
Henry and Tara.
I know Amar's on the call as well. So in the convention of care arm with equivocal findings, we might find that there are patients who've got, say, an equivocal bone lesion. In that scenario, they should Amar will be helping develop the radiology SOP, but I think we can't, if we say, oh, go and have a whole body diffusion weighted MRI, that is an advanced imaging technique. and it's not available in most centres in the UK. But I think what is available is for patients to have a dedicated MSK protocol of that particular bone area, and including diffusion sequence locally of that area. But Anwar, perhaps you can address your thoughts on whole body MRI.
Yeah, I mean, so the APCC says that morphological imaging is considered part of conventional imaging to clarify the nature of a lesion. But whole body MRI with diffusion imaging is next generation imaging. So I think we should not have whole body MRI with diffusion imaging as part of conventional imaging.
I think I'll let Henry, because Henry wants to say something on this as well, but I think we have to not allow for whole body MRI.
Additionally.
Henry?
No, I was going to say something different. So that's a separate.
Okay, fine.
Do you want to address the bone scan issue as well, which on the
Yes. Planar, or does it have to be with SPECT? I mean, I think that will get criticised in that area.
So I think Hash, correct me if I'm wrong, but I think the funders commented that ideally we should have a SPECT CT, but that's not really available widespread in the UK. So I don't think we're going to mandate exactly how the bone scan is done. It will be a scintigraphic imaging as befit local availability.
Yeah, we've been doing a survey amongst all interested centres as to what imaging they're currently offering. I know a couple of centres who have the latest CZT SPECT CT scanners, like Bath and Guildford. They're doing total body SPECT CT, but in a very short time frame, because they've got the latest scanner which have a very high sensitivity and are quicker. To do, most centres in the UK have got old scanners, which to do a whole body SPECT CT is going to be like practically 1.5 to 2 hours on the scanner. So we will come up with, I think they absolutely have to have planar imaging. We'll have a discussion in the radiology group and amongst centres that are going forward to open. It may be that that they, if feasible, get the whole body planar imaging reviewed at the time and add on a SPECT CT of any equivocal region before they leave the department. That could be an option to cover it. But yes, it is something that we've considered, but we cannot say every centre should be doing SPECT CT, because that's just not what's happening in clinical practice in the UK at the minute.
Yeah, we've got to be a bit careful about changing the control so that it becomes much better than it actually is, and much more exemplified than it is, and to the point where people just get fed up of the study because the control is also being quite dictatorial. So again, sort of, yes, this isn't quite a pragmatic study, but it's some elements have to be pragmatic. So there's a question from Gail Haran in Cambridge. We get PSMA PET under contract from Alliance. Unless, Gail, you want to ask it, do they have enough tracer to allow these extra PSMA PET scans? So maybe Henry or Tara?
Well, I think we should have radiopharmacy representation on the call. They've all been invited from the various suppliers, but I know that PSMA production is increasing and there's going to be better availability. And we're hoping that the radiopharmacy group will work together as a community to support the study. We do expect there's definitely going to be more availability by the time it opens next year. Yeah, maybe we're going to, I see as David Baker is on the call. I think we've got Alliance representation, and Siemens as well. Perhaps if you've got any comments, that would be useful. Thanks.
Hi, Tara. Yeah, it's David Baker, and yes, I completely support what you said, and in reference to our emails. So I think I'm confident in saying we're probably the biggest manufacturer and provider, and we're expanding all the time with both, well, particularly F18, DCF, PYL, PSMA. So we're already supplying about 16 sites in the south, and I can see names on here that I think are probably using it. And for the whole of the London region out to the M25, that's all covered with gallium PSMA. And in a year's time, I'm trying to recall the dates that I just saw you flash up, but certainly when we're going into 2025, there'll be a lot more. So I think we can probably solve people's problems if you direct them to me or other colleagues on here. I can't see other industry. I don't recognise other industry people on here, but certainly you can refer people to me and I can give them that availability or describe that to them.
Hi, it's Peter Strohel here, Medical Director from Alliance Medical UK. Thanks for inviting me on the call. Yeah, we are working on the PSMA production across the whole country, as you can probably imagine. We are well aware of the demand and occasional shortages, for which we apologise to the likes of Norfolk and Norwich. We know we've let them down several times. We are aware. We track it every single week. We're making PSMA 1007 from our Dinnington radiopharmacy site now, which will cover the north. We are looking at many other options, which I maybe will pick up separately with Tara or somebody in a more private setting than this. But we are looking to increase the PSMA production all the time.
Great. Thank you for all your support, by the way, and calling in, both of you, and any other commercial commercial people who are on the call. Thank you. If you want to say something, feel free to. Okay, Vincent Koo, you had another question.
Yeah, so this is much more of a colloquial issue, I think, in those trusts that may have an electronic patient record system, and we have something called EPIC at the moment. There's a move where results of patients are meant to be delivered without being filtered to all. So it's likely that that's the direction our trust is taking, which means that they will know things we will not know. You know, if they've had the test, they will know it.
So Vincent, I can answer that. So the patients will be consenting, and they'll be told in their patient information sheet and on the consent form that their result of the imaging and the imaging themselves will not be looked at by the clinical team. Firstly, that if they withdraw, they will have to accept that the imaging and the imaging report will not be unblinded to them until 48 months after they consented. And then importantly, and what we did in Promise, is the report on the EPIC system or whatever system it is will be a statement from the radiologist saying, and because it's part of a trial, this will have to be accepted. This patient's report is on the ECRF for Avidity. It is not released into EPIC or into the radiology reporting system, and will not be unblinded unless under protocol setting. And so I think obviously that needs to go through ethics and local site approval, but it's a trial and we've done it before in that way, and that allows the radiologists to meet their reporting timeline, which they're tracked on. There is a holding statement, but nothing will be
That's great, because I think that's needed, because otherwise, you know, it would you know, be limiting for many sites, I think.
That shouldn't be.
Oh,
we're back. Sorry, we had. Can somebody just say they can hear us?
Oh,
Yes.
I can hear you.
Yeah.
I think you came kind of blurred towards the end, but I knew what you were saying.
Okay,
so.
sorry. What was the last thing I said?
It was like a muffled.
Okay. Okay, fine. Did you hear the fact that I said the patient report would be blinded fully, and we would make that as part of the protocol. Okay, fine, fantastic. So we will do that. Let's take another question from the chat, please, if you don't mind.
Chat. Yeah, we've got one from Sankey.
So question from Shashi in East Kent. What parameter findings from the internal pilot of 37 patients can influence the full study? I don't know whether Rhian, you want to talk about the pilot, or we can just talk about the pilot. Martin?
Yeah, I mean, I think from the initial 37, we're going to look at compliance, breaking of that, blinding, and also that N0, M0 group to make sure we've got the sample size correct that we expect, that we observed in the PSMA study.
Yeah, the unblinding thing is clearly a critical issue, and we have a backup design where basically patients will get either standard care imaging or PSMA PET imaging, and there won't be a blinding issue. But that will require a much bigger study of about 800 or 900 patients, which is why we're going to try this very clever Rhian and Adam Brentnall advised study. So they came up with that design, and we very much rely on their expertise to guide us through that. Okay, Vineet Prakash.
Hi, thank you for an excellent presentation. Just calling from Guildford. For clarification purposes, one of the exclusion criteria is patients who've started systemic therapy such as finasteride and equivalents. So does that mean if they started hormones, that would be an exclusion criteria?
So finasteride and dutasteride are not exclusion criteria, so they can have started that. But if they've started an anti-androgen or any kind of androgen deprivation therapy, then yes, they are excluded. The key thing to know is that most of us start the hormones mainly to meet cancer waiting time targets. So the NHS England guidelines for cancer waiting time targets is that if a patient enters a treatment trial and consents to that, then the date of consent will be counted as the date of treatment for the purposes of cancer waiting time targets. So you shouldn't reach by entering patients into this and patients waiting for a PSMA PET scan. And so we would ask you to hold off on the hormones until they've had all of their imaging. So I think that's the motivation behind the question, but I may have misinterpreted your motivation behind the question.
No, you got it. So basically, there are some trusts who struggle with meeting the cancer wait time, especially for MR radiological T3N1 disease, where they try to put the patients on hormones before the prostate MDT, and they would be excluded. So there's an education piece there that what you just said would help them to understand better. Consent would close that pathway.
Yeah, absolutely. I mean, that guideline change, I was involved in making it with Nicholas Van Ass from the Royal Marsden when he advised NHS England, and we made that change a few years back. So treatment trials and consent into that will share the exact pros from the guideline and reference it, but that will meet your cancer waiting time treatment clock.
Yeah, and the supplementary question is the education piece also for patients, because otherwise there might be a drop-off rate as patients feel they're not starting their treatment.
Absolutely, thank you. Yeah, no, I think that's really important that we get that message across as well. Another question from, is it Darren?
It's Darren, hi. Hi, Hash, hi. Yeah, it's more about trials clashing potentially. Obviously, Stampede 2 is on the horizon, about to start anytime soon. Now, obviously, I know this study is it's more in the diagnostic aspect of it all, and we may find by chance people with polymetastatic disease, but in those patients, maybe only a few. If someone has a PSMA PET and it's got they may feel as though they want to enter Stampede 2. Is there any way of them doing that or not?
I think because the study is so protocolized in that first 4 years, we would have to disallow sort of co-enrollment. Obviously, there's nothing to stop them from withdrawing, and every withdrawal is is sort of hurts the primary trial, but there's nothing to stop them from withdrawing and going into another study. But I think co-enrollment would be quite difficult to justify.
Yeah, I thought I just wanted to ask because I just think it could be a bit of a problem. That's all potentially.
Absolutely, and we weren't exactly sure about. I was hoping this study would be funded, as you know, 3 years back, and we would have finished recruiting before Stampede 2 opened. But as it happens, and we are talking to the other trial teams, and we'll have a chat with the Stampede team. But the other study that is competitive is Ellipse, which is looking at lymph node dissection. And we've had a conversation with them as well. So I think there's different solutions for different centres.
Yeah.
Some centres will want to take part in just one of the studies, and we won't be offended if centres choose another study. Some centres want to take part in both, and maybe one way of doing it is to do either 6 months recruitment into one and 6 months recruitment into another, or you pulse it. The other hybrid solution is you offer one study first, and so you offer Avidity first because that's where the diagnostic staging is. And if they say no, they may want to take part in Stampede later on, or they may wish to take part in Ellipse if they're going to have surgery and they need lymph node dissection. So that is those are 3 solutions that each centre could take on in terms of competing studies.
Maybe I'll just add to that we looked at the data from our diagnostic pathway to look for those high volume patients who are M0 on a pelvic MRI, and it is rare. And those who are in that oligo-met space, we're actually offering them intensification within the study, which may well be similar to what they've been offered in Stampede. So yes, it will happen, but it will be small numbers, and we might be able to facilitate it alongside.
And it probably won't make that much of a difference. But no, that's a really good point. But it's a really good point. I'm glad you raised it because I was hoping somebody would raise competing trials. we will push for our own study, but I want all of those other studies to succeed. So we're really good in the UK at supporting each other, so we'll continue to do that. Vincent and then Sangeeta.
So just really want to add something to Darren's comments as well. So you may or may not be aware that the difference could be a lot less between Stampede and Avidity now, because Janssen has withdrawn funding from Stampede 2. So one of the arms have gone to, looking at.
Okay.
But that's just the olaparib arm.
Yeah, just the olaparib arm.
Janssen's funding.
No, sure, but it means that the main intervention arm is therefore very similar to Avidity. I see what you mean. Yeah. Okay. Well, I'm sorry about that. That's a shame. Okay, Sangeeta. We can read out your question probably. I can't. My eyesight is getting worse.
So with the new AI protocols with whole body MRI scans and reporting will be quicker than SPECT CT, could you have incorporated a comparator arm with CT and whole body MRI?
I think it's. If I interpret your question right, you may be asking whether we should have had a third arm, maybe. Or maybe I'm happy for you to clarify your question. Sorry.
Can you hear me?
Yes.
No, I meant a third arm. A third arm with a CT and whole body MRI, because I mean we do quite a few whole body MRIs. If there is if there's any concern that there could be a suspicious lesion for our patients, and not necessarily a bone scan. So that is why I was asking whether a CT and WB MRI would be an arm that you could recruit to. I mean, I don't know, that would obviously increase the numbers you would have to recruit to the trial, but I think Rhian has answered that yes to that answer to that question.
I mean, the thing about whole body MRI, I know he may have had to go to collect his daughter, but it's not great for nodes. It's good for bones, and picking up small volume nodal disease on whole body MRI is not ideal. It's not widely available. It's not standardized. So the most that we do it routinely at Imperial for myeloma. We're not doing it for prostate. I think that's a separate study entirely. Personally, I think it's too much because it's already got escalation norms, etc. And I really think there are not enough centres offering whole body diffusion weighted MRI to incorporate into Avidity. I may be wrong. Anwar might have other thoughts. Which centre are you at, Sangeeta? Remind me, please.
Basingstoke.
Basingstoke, yeah.
Okay. I mean, it's a question that keeps on cropping up, doesn't it? And I think we were going to have to reflect on it. It will be a conversation internally to see if a third arm is feasible, and then obviously a discussion with the funder. But you know, it keeps on coming up, and whilst previously I was sort of, well, no, let's. But let us have a think about it, if you don't mind. We might get you and the other whole body MRI people in a room together and see what the appetite is. But it's something that we should probably at least think about seriously, whether within this study or as a separate.
Yeah.
But you've the whole body MRI story has been taken over by the functional PET imaging story, hasn't it? So
no, that's true. But the only thing is
that doesn't mean it should. That doesn't mean it should. It just
no, I get that. But with the whole body, it's not for nodes because we are already doing a CT, if you see what I mean. So we are using that to stage bones.
Sure.
Got it.
Let's have a think, and if we think there's some scope, then we'll loop everybody in. Cool. Anything?
I've got no other questions in the chat.
No other questions in the chat. Anybody else? Good. Sangeeta.
Sorry, just another question. You know, the patients who are on hormonal therapy, as Vineet has just mentioned, you know, are going to be excluded from the study, but there are patients who do have increased PSMA expression on starting hormones. So they will be completely off. They won't be off for the trial if they've started hormones, even though we know that there is an increased PSMA expression, you know, possibly within the first 4 weeks of commencing ADT.
It's actually, it's within the first 7 days of commencing ADT. You can get increased expression, but then it can go rapidly down after that. And I think we just it's going to muddy the waters if we let patients start ADT, and we have to keep it that they're hormone naive.
Okay, thank you.
I'm hoping that the trial meets cancer waiting time will help centres recruit these patients without worrying about starting them on hormones. So let's see how that goes. But good. Look, everybody, thank you. It's a Friday afternoon. It's late on a Friday afternoon, and I'm so appreciative of everybody joining, and my colleagues here around the table as well joining us. A lot of you on the call have helped us with this study, and I didn't know who was on the call, so I apologize for not specifically pointing you all out, but you've all been fantastic. Everybody who's participated in the calls with your questions. I hope as many of you can take part in the study. I think it's going to be a really exciting one to answer. And again, as one of the funding panels said, it's something that only the UK could do and take forward. So I hope you will all join us in that endeavour. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Hash, can I have a quick word if that's possible?
Yeah, of course.
Sorry, it's about what.
You're still being recorded.
Got you. It's just in regards to the.
Darren, you're still being recorded.
Sorry.
Let's stop the recording and let